Migraine headaches.
I can do that.
I would love that. Thank you.
I forgot what I did for my presentation for a second. Hold on.
I know. It was a long time ago. I never had a class this big. We always would get through them in the first day, but this class is so big we're spilling over, which is a good problem now.
Let me share my screen.
Oh, I love that. We'll take it.
Okay. Okay. Oh. Okay, can you see it?
Let's see. Hold on. Just switch around. Yes! It's great!
Okay. So I have migraine headaches. What is a migraine? A migraine headache, it can cause severe throbbing pain or like a pulsing sensation, usually on one side of the head. It's often accompanied by nausea, vomiting, and extreme sensitivity to light and sound. Migraine attacks can last for hours to days, and the pain can be so severe and intense that it actually affects your daily activities. And for the first time, I think I got one this weekend. My head was throbbing, and I didn't, party or anything. I actually just went to work the day before, and the next day my head was hurting so bad, I couldn't even get out of bed. The light was killing me, so I just laid in bed all day. But something that causes migraines, it's not fully understood, but genetics and environmental factors can play a role. There's changes in the brain stem and its interactions with certain nerves, and there's a major pathway that's involved with that. So there can also be imbalances in brain chemicals, including serotonin, which helps regulate pain in your nervous system. And then they're still trying to study the role of serotonin in migraines, but other neurotransmitters play a role in the pain of the migraine, including calcitonin, which is a gene-related peptide. Symptoms of migraine. So again, we have pain in the face or neck. It can be dull. So it can be acute pain or frequent and throbbing. So you would again have sensitivity to light, distorted vision, or seeing flashes of light. You can also get dizzy, lightheaded, or malaise, which is just the general feeling of discomfort. And then sensory is aura or sensitivity to sounds. And then, your stomach will be messed up, so again, nausea and vomiting. And then be irritable, nasal congestion, and scalp tenderness. And then there are two main types of migraine. So you have migraine without aura, which is a common migraine. So most people with migraines have common migraines. This type of migraine causes a throbbing pain on one side of the head. The pain is moderate to severe and gets worse with normal physical activity. You may also have nausea and vomiting and may feel worse around light and sound. The headache lasts 4 to 72 hours if not treated. A common migraine does not begin with an aura. Migraine with aura is or a classic migraine. Some people with migraines get an aura up to 30 minutes before the migraine. Symptoms of the aura include seeing wavy lines, flashing lights, or objects that look distorted. Other symptoms include tingling or pins and needles feeling. And then I just put a picture with some more migraine with aura symptoms, so you can get a better visual understanding of what that's like.
It's beautiful.
And then migraines versus headaches. So they both have the steady ache and mild to moderate pain in common. The tension headaches is just like the dull tightness and distracting pain, but not debilitating. But then migraine obviously is way worse with the sensitivity to light, moderate to severe pain on one side. And then treatment. So for self-care, you could do stress management, improve sleep habits, avoid migraine triggers, such as like caffeine and nicotine and things of that nature, and diet modification. Medications. You can take certain type of anti-inflammatory drugs or stimulants, nerve pain medication for this. And then therapy. You can do progressive muscle relaxation and acupuncture. For massage therapy for migraine, so lower levels of serotonin are believed to be linked with migraines. Massage therapy can help increase serotonin levels, not only lifting your mood, but also relieving migraine pain. It also will help with tension relief, so massage therapy, especially head massages, have been used to relieve tension, which helps to alleviate migraine pain. This tension relief also occurs immediately during the massage session. And then easing pain signals. Massage therapy is used to reduce pain for many illnesses, including migraines. Some type of massage release pain-easing chemicals that help to reduce the pain signals to the brain, which is also believed to reduce the amount of future migraines. And then where to massage on the migraines. You have some acupressure points for relieving headaches and migraines. So you have one between your thumb and your pointer finger, which they call the joining valley. Then your gates of consciousness, which is like the occipital ridge that Mystery Bar is always telling us about. There's also a spot on top of your foot. Then you have some pressure points on your neck. And then I think it's like right around the cheekbone area. And then right around the eyebrow area. That can help with relieving the tension in the head and for your migraine.
I love the shelves. Very cool. Very good. Thank you. It's exactly what I wanted to know. Yeah. Nothing more to say. Massage will not cure migraines, but it does seem to make them come on less often and be less severe. And migraine sufferers will pay for that. I have a friend who takes, I think it's like Emitrex or something. Like if she feels a migraine coming on, she pops a pill and it'll stop it. The pills are $50 a piece. $50 a piece. And we were at a party and a stranger goes, oh shoot, I got a migraine coming on and I don't have my Emitrex or whatever it is, the same stuff my friend took. And my friend literally reached into her purse and gave her the pill, and the lady's like, let me pay you for that. And she's like, no. She's like, I am a migraine sufferer. I know how bad these things are. So it's so bad to her, she could relate so much that she was willing just to give her a $50 pill. Kind of let me know like how bad these things are, because I've never gotten a migraine. Mr. Overman.
I just had a thought. I was wondering, like Adderall helps release dopamine and serotonin or whatever in your brain. I wonder if that would help with migraines.
Yeah, it could. I don't know. Be very interesting to see if people that took that reported less migraines. Yeah, I don't know. And what I worry was, would it come on afterwards too? Like, would you have to pay the piper eventually? But you are absolutely right. Adderall releases that stuff in pretty large quantities. Yeah.
Yeah, I take it occasionally, but because I got prescribed it when I was trying to be a writer and realized I couldn't sit still long enough to write anything. But I haven't had a migraine since I've been prescribed it. But if I do, I'm going to try it, see if it works.
Yeah, please let me know. That would be fascinating, actually. You could stumble across something that nobody else has figured out yet. I mean, it happens all the time. Miss Osuna, did you have your hand raised and then not? I just didn't want to ignore you.
Yeah, I did. I was just going to say that it never worked for me, the Adderall.
Oh.
When I agree.
Got it. Okay. Well, worth a shot. Yeah, we'll see. Miss Hendrickson.
I was wondering if it ever, comes on and then goes into remission or something, because when I was, in middle school, I think I had migraines. I was never diagnosed, but I had really severe headaches like that. They would last a long time, and I had like blurry vision a lot, and like really sensitive to light and sound. But then I don't know, it only lasted for like a few months, and then I haven't really had them like that.
They do go into remission. I know for a fact. I've had friends who were like, got migraines all the time, and then didn't get them for 4 years straight, and then started getting them again. And then they're like desperately trying to figure out, what did I do different during this time?
Right.
So yeah, I think they can go into remission, so to speak, or whatever was doing it to is not doing it anymore, or whatever. Yeah.
Interesting.
Yeah. Cool. All right. Excellent. Next up, Ms. Dimitruk is going to tell us about multiple sclerosis. Please.
Yes. All right. Okay, multiple sclerosis. And I might be again pronouncing this the British way. Okay, multiple sclerosis, or MS, is a potentially disabling disease of the brain and the spinal cord in the central nervous system. In MS, the immune system attacks the protective sheath, the myelin, that covers the nerve fibers and causes communication problems between your brain and the rest of your body. Eventually, the disease can cause permanent damage or deterioration of the nerves. Signs and symptoms of MS vary widely and depend on the amount of nerve damage and which nerves are affected. Some people with severe MS may lose the ability to walk independently or at all, while others may experience long periods of remission without any new symptoms. There's no cure for multiple sclerosis. However, treatments can help speed recovery from attacks, modify the course of the disease, and manage symptoms. So, neuron anatomy. Neurons are the pulse-conducting cells that represent the simplest structure of the nervous system. Neurons have the three basic parts, which is the cell body, the dendrite, and the axon. Oligodendron chorocytes in the CNS and swan cells in the PNS are the glial cells that produce the fatty myelin sheaths around the axon, and that's those yellow little tubes on there.
Yep.
And myelin increases the conduction rate of the impulse and provides insulation to prevent impulse leakage to the adjacent neurons. The multiple sclerosis neuron. Again, we have the good normal neuron here, and the myelin can be compared to the insulation coating on electrical wires. When protective myelin is damaged, the nerve fiber is exposed. Loss of myelin ultimately leads to scarring or sclerosis and plaque formation, and the messages that travel along the nerve fiber may be slowed or blocked. Symptoms of multiple sclerosis. Movement. You might have numbness or weakness in one or more limbs that typically occurs on one side of your body at a time, or your legs and trunk. Electric shock sensations that occur with certain neck movements, especially bending the neck forward, like a hermit sign. Tremor, lack of coordination or unsteady gait. In vision, partial or complete loss of vision, usually in one eye at a time, often with pain during eye movement, prolonged double vision, and blurry vision. And then general issues are slurred speech, fatigue, dizziness, tingling or pain in parts of your body, problems with sexual, bowel, and bladder function. Risk factors that increase your risk of developing multiple sclerosis. Age. MS can occur at any age, but usually onset occurs around ages 20 through 40 years of age. However, younger and older people can be affected. Sex. Women are more than 2 to 3 times as likely as men to have relapse and remitting MS. Family history. If one of your parents or siblings have MS, you're at higher risk for developing the disease. Certain infections, a variety of viruses have been linked to MS, including Epstein-Barr, the virus that causes infectious mononucleosis. Race, white people, particularly those of Northern European descent, are at highest risk of developing MS. People of Asian, African, or Native American descent have the lowest risk. Climate, MS is far more common in countries with temperate climates, including Canada, Northern United States, New Zealand, Southeastern Australia, and Europe. Vitamin D, having low levels of vitamin D and low exposure to sunlight is associated with a greater risk of MS. Certain autoimmune diseases, you have a slightly higher risk of developing MS if you have other autoimmune disorders such as thyroid disease, pernicious anemia, psoriasis, type 1 diabetes, or inflammatory bowel disease. Smoking, smokers who experience an initial event of symptoms that may signal MS are more likely than non-smokers to develop a second event that confirms relapsing remitting MS. Massage therapy for multiple sclerosis. Massage therapy can't cure or change the course of the disease, but for some people with MS, massage therapy can be helpful in easing certain symptoms and improving overall quality of life. MS is different for each person who has it, so potential benefits of massage therapy will also vary from person to person. Overworking the tissues can leave a person with MS feeling bruised and fatigued. Massage therapists who use hypotherapy applications such as hot packs, this may not be appropriate for a person with MS. Some MS symptoms that might improve with massage are spasticity, pain, fatigue, poor circulation, stress, anxiety, depression, and it can also help prevent pressure sores, boost your mood, and improve physical and social functioning.
Well done. Thank you. Thank you. Yeah. Yeah, massage isn't going to cure it, but could bring quality of life back for people. Also, anytime people have a hard time moving, things like that, massage helps keep blood flow going, all that good stuff. And you test the carpet on this one, right? You, with somebody with MS, you don't do an all-out hard massage on them. You see how they respond to kind of light pressure first, and you might move up to medium pressure, assuming that they're doing fine. But you check in with them the next time you see them. Yeah, because you just don't know. That's well done. Thank you, Mr. Mitrak. Beautiful. I love it. Miss Dang. Miss Dang, are you there? Where did Miss Dang go? Oh, there she is. Hi, Miss Dang.
Hi, sir.
Can you tell us about Parkinson's disease?
Okay. Hello, just 1 second. So this is a party you and son.
Parkinson. Oh my God, you spelled out the thing with pictures. I love it.
My husband told me how to say the words correct.
That is so clever. Parkinson's disease. Beautiful.
Yes.
I love that. Thank you for sharing that.
But I know Parkinson's disease is a very serious disease because my husband uncle he has 30. When he was a pilot, he had a critical job, and when he's 50 now, it's more than 30 years. He's shaking, couldn't talk very well, so it's suffering for more than 30 years. So, and also I met him once. He's living in Arizona, and Parkinson's diseases, the central nervous system that affect the movement and also including the tremors. Nervous system damage into the brain cause dopamine levels to drop, leading to the symptoms of the Parkinson's. Parkinson's often start with a tremor in one hand. Other symptoms are slow movement, stiffness, and the loss of the balance. Medication can help control the symptoms of Parkinson's treatment. And you can do physical exercise. We can massage for the Parkinson's disease. Massage can help to relieve the muscle stiffness and the rigidity that is often found in Parkinson's. It can also help reduce the stress, promote relaxation, and enable you identify tense in your body, and so you always to minimize or reduce it. Thank you.
Thank you. That was perfect. So, yeah, essentially this is a disease. It's a chemical imbalance in your brain. Actually, there seems to be some degeneration in a part of your brain that produces dopamine, and dopamine does all sorts of stuff. It's a mood stabilizer, but it also helps with the proper firing of your nervous system and how you function, and that's why movement, all sorts of stuff becomes challenging, because this is a chemical imbalance in the brain. But again, definitely can massage individuals with Parkinson's disease. It's completely fine. Quite often it's helpful in just alleviating some of the shakiness they have and things like that. But it obviously won't cure it at all. Thank you, Miss Deng. That was perfect.
Thank you, sir.
I love the park in sun. That was good. That was really good. It's great. Miss... How are we doing? Oh, we're doing great. Mr. Craven, you were going to tell us about sciatica.
Yes, I am.
And I can hardly wait, sir.
All right. Well, you know what's crazy is the day before we got assigned these, I'm pretty sure I had like a rare instance of like a flare up for this, and it was like one of the most painful things like I've had in a while because it just came out of nowhere.
This concerns me, sir, because I assigned migraine headaches to Miss DeBose. She got a migraine headache. I assigned sciatica to you. You get a sciatic thing. It's kind of voodoo-ish. I gotta be careful.
Witch.
When,
Burn the witch.
when we get to cancer, I'm going to cover that one myself. I won't assign it.
Yeah. Well, don't give that to anybody.
Right.
Please.
Well, yeah. Okay, so you might have a little flare-up with it. So you're kind of experience that maybe burning sensation in your...
I mean, it could have been this.
Yeah.
From what I read about it, it seemed like it was this, but it could be something completely different. But sciatica is inflammation of the sciatic nerve.
Yep.
Which runs from your lumbar, crosses through your pelvis, and runs down your legs.
Yep.
The pain from this condition is usually in the lower back or hip and will travel down one side of your body.
Yep.
And it's most commonly a symptom of another condition, usually like a herniated disc, something along those lines, as these put pressure on your sciatic nerve branches, but can also be caused by bone spurs, trauma, poor posture. To massage those with this condition, it's recommended to postpone the massage if the sciatica is related to a herniated disc and the pain is like really severe. And it's also recommended to use a softer style bolster when supine, as people have like really sensitive pressure points behind their knee. Otherwise, pretty much treat it as normal. And I really was trying to come up with something like funny to say about sciatica. Did a lot of research on it, but you know, it ended up really just being a pain in the ass.
I was waiting for that. Yes. Yeah. That is exactly what it is, though, everybody. It's a pain in the ass. It's your sciatic nerve, this massive nerve that forms at your sacrum and goes down the back of your leg. I've actually never had to cancel a massage because of sciatica. People usually come to you with sciatica. You work the snot out of their lumbar region, their gluteal region. There is one of your deep 6 lateral hip rotators, which is also thought to possibly pinch the sciatic nerve. Does anybody know which of the deep 6 lateral hip, Miss Abelos, which one is it?
Piriformis.
Piriformis starts with a P, and so does pinching. Piriformis pinches the sciatic nerve. By the way, other deep 6 lateral hip rotators might actually play a part too, but that's the one that every massage therapist, you'll hear, you won't go a week with working somewhere where somebody doesn't mention the piriformis. Good stuff. Thank you, Mr. Craven. Thank you. Ms. Clayton. Ms. Clayton, you were going to tell us about seizure disorders. I hope. That would be delightful. Miss Clayton, do you hear me? Miss Clayton, where are you? Oh, she's bringing up her thing. Sorry, Miss Clayton, we got you. By the way, you're muted. I think you should know.
Sorry, it was trying to share my screen and it wouldn't let me unmute myself.
Got you. No, you're fine. I just wanted to, yeah. Anyway, you're good.
Okay.
And we can see your slideshow. Now we can really see your slideshow. Yeah.
Oh, good. So I had seizures. Seizures are uncontrolled electrical disturbances in the brain. You can think of seizures as a lightning storm going on in your brain that you can't control, that you don't know what caused it, and that you don't know when it's going to be over.
Well said.
The neurons are our nerve cells, and in the brain, they create and send and receive electrical signals from all areas of the body. But anything that disrupts these neurons can lead to a seizure, and we'll talk about the different things that can cause seizures. When most people think of seizure, they have that image of the person falling on the ground and shaking and uncontrollably unaware of what's going on around them. That's only one type of seizures. There's many types of seizures, some where the person, is conscious through the whole time and knows what's going on. And I'll talk about those a little bit. They're relatively common. The data says that at least 1 in 10 people will have some type of seizure throughout their lifetime. What it's interesting is seizures can cause changes in, 1 is your behavior, 2, movements. You think of the grand mal seizure when people are falling on the ground and, having all those crazy movements. Not all seizures have that impact. Feelings, people can have bizarre feelings with seizures, like deja vu, or impending feelings of doom. And then some levels of loss of consciousness during some types of seizures. Epilepsy is a condition where people have seizures frequently or relatively, on a consistent basis. They define epilepsy as if you've had 2 or more seizures at least 24 hours apart that are not brought on by an identifiable cause. Yeah. Most seizures will last from 30 seconds to 2 minutes in length, but they do say that if someone has a seizure lasting longer than 5 minutes, it's a medical emergency and you should call 911. Yes. Most seizure disorders can be controlled with medication, but the management of seizures can have a significant impact on daily life just because of the unpredictability of it. And some people, are not able to drive and things like that. So depending on the severity of the seizures, it may change your life to some degree. The most common cause is epilepsy, but it can be triggered by a lot of different things. So strokes, head injuries, brain bleeding, infections such as meningitis can cause seizures, high fevers, which can be associated with an infection such as meningitis. But you worry, when children are young, when they have really high fevers, you worry about them having seizures because of that. Lack of sleep can cause seizures, flashing lights. Low blood sodium can cause seizures, so people that are going through any type of diuretic therapy. Certain medications can cause seizures.
So you have to make sure that, there's no risk with different medications. Autoimmune systems, lupus can cause it, multiple sclerosis can cause it because of the damage to the nerves with those diseases. And then certain drugs, illegal drugs, can cause seizures. And finally, alcohol misuse or any type of detoxification.
Yeah.
So some signs and symptoms that may occur prior to a seizure are temporary confusion, staring spells where the person just seems like they're in a daze of some sort of, they're just not really responding and they're in a daze, uncontrollable movements of arms and legs, loss of consciousness or awareness, and then cognitive or emotional symptoms, fear, anxiety, deja vu, etc. There's two types of seizures. One is focused and one is generalized. So with focused seizures, the electrical problems, the impulse problems, the nerve problems are just happening in one area of the brain, whereas with generalized seizures, the entire brain is affected by how the neurons are misfiring. So then there's the different types. So, and this is just a few. There's more than this. I just did this as an example, but they categorize that seizures into, they can be tonic seizures, and those are the ones that have the stiffening of the muscles, usually impact the arms, the legs, the back, and may cause you, not always, but may cause you to lose consciousness and fall to the ground. Then they have clonic seizures, which are associated with repeated or rhythmic jerking muscles. These ones usually affect the neck, the face, the arms, and then you can combine those two into the tonic-clonic. And this is normally what we think of when we hear the word seizures. It's the ones where people are on the ground and they're convulsing and uncontrollably, and their body stiffens and shakes. Sometimes during these seizures, the person having the seizure can lose bladder control or end up biting their tongue, and it may last for several minutes. And then myoclonic seizures, they appear as sudden brief jerks or twitches of your arm. There's often no loss of consciousness. So sometimes you'll see someone with different illnesses or conditions, and you'll see them do the brief jerking or twitching, and that can be associated with very small, short seizures. When to see a doctor? If you ever experience a seizure for your first time, you want to seek medical advice to see what caused that seizure. Like I said before, if it's more than 5 minutes, something really not good is happening. Obviously, if your breathing or consciousness does not return to normal after the seizure, that could be a sign of a stroke or something more serious. If you have a second seizure right after your first, high fever, heat exhaustion, if you're pregnant and have a seizure, if you're diabetic and have a seizure, many times that's due to low blood sugar. And then if you've injured yourself during the seizure, obviously, if you've fallen or hurt yourself. So with seizures, obviously, if you can think about falling down and losing consciousness, a lot of problems can occur due to that. So if you fall, depending on where you fall, you could hurt your head, hit your head on something, break a bone. If you're in the pool and have a seizure, the risk is you could drown, especially if you're by yourself. Car accidents, you can lose control of your car, awareness. Actually, my landscaper, this happened to him, and he no longer can drive because he had a seizure, and a really bad seizure. He fell asleep at the wheel, and he actually killed someone driving, so he can no longer drive. He actually has to have a driver that drives him around everywhere. And his seizures are still pretty bad, so they can happen at any moment. But this is going back to, depending on what type of seizures you have and the cause, it really may impact your life. Pregnancy complications, again, if you're pregnant and you have these seizures, depending on if you fall or, how long, it could affect the baby. And then the other associated problem is emotional health issues. So if people have these severe seizure disorders, that can lead to depression and anxiety because you're worried about them happening, and you're depressed that, your life is altered. So Massage and seizures. Massage is fine for anyone with seizures. There's really no major contraindications. Stress-related seizures are, they often tell the patients with that to get massage. If you do have a client that comes in with a history of seizures, you want to ask them if they have any known triggers, things that will set their seizures off, and then obviously avoid those. And then a couple things that are maybe contraindicated is aromatherapy. A lot of times smells can trigger a seizure. And then flashing lights. So if you're, you have a room with adjustable lighting or anything like that, you want to avoid doing a lot of, turning on and off and low and high, that sort of thing. For treating seizures, if somebody has a seizure in where you are and you're there, you want to just basically stay with the person, make sure they don't injure themselves, make sure that you stay with them until they wake up. Let them know they're in a safe place and everything is okay once they become alert. Tell them what happened in simple terms. Don't, just say, I think you had a seizure, you're awake now. Comfort the person, speak calmly. See if they are wearing a medical bracelet or emergency information. So you can call that number. Keep everybody calm. And then if the person drove to the location themselves, see if you can get someone to come and pick them up, or call, an Uber or someone so they can get home safely. So the grand mal seizures, those are the ones that are really, they're falling unconscious, and you want to help them get to the ground again so they don't hurt themselves falling or, hit their head. They say to turn the person onto their side. It helps them breathe better. Clear the area so that there's nothing around them, again, that they can hurt themselves on. If you have anything soft, you can put that under their head, again, to minimize any type of head damage. If they're wearing glasses, take those off. Again, this is all really aimed at minimizing any type of self-inflicted harm that, they're not aware of what's happening. If they've got anything around their neck, get that off or make sure that they're able to breathe. And then if the seizure, again, is longer than 5 minutes, you want to call 911. And then the last thing they caution is if someone is having a seizure, don't hold the person down or try to stop his or her movements. You're not going to be able to. It's just got to run its course. Do not put anything in the person's mouth that's kind of a wives' tale. You don't want to try to hold their tongue down or anything like that. They said that they really cannot swallow their tongue, so they might do things with their mouth and their tongue, but you don't want to get in the way of that. And then do not try to give them any type of CPR or things like that. Normally people will start breathing fine just on their own after the seizure. And then don't offer them food or water until they're fully awake and alert. And that's it on seizures.
That was fantastic, Ms. Clayton. Thank you for covering this, because you guys could have a client seizure on you. That's not that uncommon, I hate to say. And Ms. Clayton already said this. She said it beautifully, but I'll just repeat it. Kind of the three things that you really look for before determining if you're going to call 911. If they've never had a seizure before, like this person's never mentioned having seizures to you, it's not a bad idea to call 911 if they've never had a seizure before, strangely enough. If it lasts longer than 5 minutes, you call 911, even if they have seizures regularly. If it lasts more than 5 minutes, you call 911. And after their seizure, if they seem to still be having a problem breathing or walking and moving around, you call 911 for that, because it suggests some complications that are kind of lingering. But if somebody comes in, they're like, occasionally I get seizures, and they seizure on your table, you just make sure they don't roll off the table, and you sit with them there, and, usually in a minute or so, it kind of goes away, and you're just very calm. You're like, oh, I think you just had a seizure, and it's fine. They're pretty common. So that was really well done. Thank you, Ms. Clayton. Thank you.
Thank you.
Ms. Carrillo, are you ready to tell us about thoracic outlet syndrome?
There was a lot of information on this, and I hope I got it correct. But I tried to condense it as much as I could and try to simplify it. I hope even I understand it.
Yeah. Well, we'll discuss it afterwards. But I'm confident you did.
Okay. I had to do it in my art program because of some layers, so there's going to be a lot of clicking and stuff.
I love this.
All right, so thoracic outlet syndrome is a condition with compression of the nerves, the arteries, and the veins,
I love it already.
aka the neurovascular bundle, in the passageway from the lower neck to the armpit. There are 3 different types of thoracic outlet syndrome, such as the venous, which is mainly the veins, the arterial, which is the arteries, and then the neurogenic. So we will be mainly focusing on the neurogenic, as this is the most common type, and the other types are mainly covered out of our scope of practice because they require like medications or surgery. So let's see. The thoracic outlet refers to the area between the first rib and the clavicle. So let me move that. So mainly right there, the first rib and the clavicle, where the brachial plexus and the subclavian artery and veins pass through. Sometimes they are compressed by anatomic defects, such as an extra rib above the first rib, which would look like this. It was really strange. So it's placed like right here. Or in an unusually tight band of fibrous tissue connecting the spine to the first area. So what also can affect them is the tightness of scalenes or the pectoralis minor. So here's the pectoralis minor. Let me put the ribs back in. Because there's so much traffic going through here, this being tight can clog it all up. And then I drew a quick picture of the scalenes to show that there's like a triangle area here, and this is where like the nerves could be. And this is like the first rib. So these scalenes, this danger triangle zone, this can pull the rib up.
Yep. Is that a breakfast one? Good. I love the shelves.
And then signs, how to recognize it. There are signs. There is pain in the neck area, the shoulder, the forearm, and the hand. There can be weakness, and there can be loss of sensation in the ring finger and the little finger. Here are some clients that we will most likely get. They could be suffering from a car crash, so an example would be whiplash. This is when the scalenes could get compressed. So right here, this is where the scalenes are at, and it's in that danger zone. Some others is poor posture, and also having like heavy backpacks and forward shoulders. So we might get like students or office workers, because right here where this backpack strap is at, it's literally compressing. And if you see here, it compresses the clavicle and the subclavicle, and the first rib, and they compress the brachial plexus and subclavicle artery and vein. And then we could also get weightlifters because of the coracoid process being in such a high area, as seen here. So the pectoralis minor could compress it because it is tight. This also can affect pregnant women as well. Okay, so this is also a way to recognize it, but we cannot diagnose, but we could do some simple tests. But we cannot do this a lot of times, as these are messing with nerves, and nerves get very sensitive. One of them is that we abduct the arm. So we go this way first. We would abduct the arm, and then we can rotate the hand into supination, so palm facing up. We extend it, make sure the arm is extended out, and then you can ask them, easier first, to rotate the head this way. and tell them to do it slowly, because if they have complained of pain in this area, it might be very uncomfortable. If they're feeling uncomfortable this way, you might not even need them to go this way. But if they seem fine, ask them to rotate their head this way and see if that's uncomfortable for them as well. Something that I saw online that said if pulse is lost around this area, it could be thoracic outlet syndrome, as it is the radial pulse, if I remember correctly. All right, so can we massage it? Yes, we can. We definitely can massage these, but we should start off gentle, and I believe it was also Ms. Eversole's presentation that named all the different techniques. So basically you can do myofascial release, trigger point, massage, cross fiber fiction, muscle stripping, and gentle passive stretching. You just have to be gentle. And if you feel a pulse, like in this area, you're on an artery. So please be careful with that. So it is we can use our scissor method that we learned from Mr. Ibarra, the 2-finger, which is here. You can use it around the neck. And it's usually like the correct size for the danger zone, the danger triangle zone. So you can massage it proximal to affected area first, which would be the neck, as shown in the triangles, under the clavicle. So we can do the scissor method on the clavicles, your pecs, especially the minor. You can do the whole arm, and you can do the hands. And also, if they are having pain as they are laying down, be sure to put a pillow for the affected area, and have the pillow raise their affected area above the heart. And that's it for my presentation.
Wow. How did you feel about that presentation, Miss Correa?
I was so nervous. It's the beginning part that really messed with me. I had to ask Mr. Ibarra to clarify some things, which was the 3 different types, and I learned that the other 2 types were more out of our scope. So that's why I focused more on the other one. The other 2 might need surgery or maybe even blood thinners. So if your client's taking blood thinners, it's because there could be a clot that could happen if I want to say, was it the subclavian? I don't remember. The vein one?
Yeah.
So, yeah, so I would try to make it simple because I had a hard time understanding it. So if I could draw it, then maybe people can understand that.
Yeah. Well, let me just fill in a few things that she left out. And that's it. She left out nothing. That was perfect. That's exactly right. It was fantastic, Ms. Carrillo. The visuals were mind-blowing. For some reason, it just simplified a very complex thing. You told us where to massage. We saw the bones it was running under. I just loved it. Everybody, you will get people with thoracic outlet syndrome. And remember, carpal tunnel, what we think is carpal tunnel can be thoracic outlet syndrome or both. So anybody that you think has carpal tunnel, you're going to do the thoracic outlet syndrome stuff that Ms. Carrillo just talked about. Just to be on the safe side, because we don't know where that nerve is pinched. That was beautiful. Unbelievably. You simplified something that's very complex. I loved it. Okay. Miss Avalos, you have something actually fairly complex, Miss Avalos. Trigeminal neuralgia.
All right, so trigeminal neuralgia is also called tic douloureux. It's French for painful twitch.
Oh.
It's a condition that's characterized by chronic pain coming from the trigeminal nerve or the 5th cranial nerve. It starts at the top of the ear and divides into 3 to the eye, the cheek, and the jaw. It usually occurs when the myelin sheath of the nerve becomes damaged or worn away. Sometimes it's caused by a blood vessel or tumor compression on the nerve, multiple sclerosis, facial trauma, or dental procedures. It's a neuropathic disorder described by many as the most painful condition known to mankind. The pain is often described as a sharp, stabbing pain with an electrical sensation. It can be so severe that the affected person cannot brush their teeth, eat, drink, or even talk. The pain comes through in a matter of seconds through the face, and as the condition progresses, it can last for several minutes. It can come and go spontaneously, or it can go into remission depending on the cause. There's a ton of stress on the mind and body for people who suffer with this condition. They live in a constant state of fear and anxiety that the pain will occur at any moment. Perpetually being in this state significantly reduces gray brain matter. It kills neurons and it causes additional disease inside the human system. There's no known cure for this. However, it is treated with anticonvulsants, antidepressants, different types of opioids, and muscle relaxants. Medical marijuana has also been shown to alleviate neuropathic pain, making it a valuable treatment for trigeminal neuralgia. Some scientists say that the concept of pain in most people begins in response to any type of injury. It's then reinforced by repetition or repeating the same response to an injury, whether it's real or perceived. This creates a neural pathway, and the repetition makes it the dominant pathway that the impulses always travel. What if I were to tell you that neuroscientists have found a way to rewire the brain to process pain differently? Neuroplasticity is the brain's ability to modify, change, and adapt your neural pathways. They've concluded that the brain can modify its established connections or completely reprogram or rewire itself. They've developed brain mapping, and it's a diagnostic tool that they use to find what your current connections are. And then they have in turn developed a training to correct or rewire those connections. This training is tailored to each individual and condition, as no two people are the same. With pain, it's processed in the prefrontal cortex of the brain. So they've specifically designed training that tailors to correcting the processing in the prefrontal cortex. Now, this training it's really a combination of things, but it's lifestyle changes, different types of brain games that they specifically designed through color and sounds, movements, learning new things, processing information differently. And they have these centers all over the world that they can help you retrain your brain to process things differently. Massage therapy is an effective treatment for those with trigeminal neuralgia. However, if there is a flare-up, then massage should be postponed. When you treat these patients, they say that you should keep them out of a prone position and do not put a lot of pressure on the face and the scalp, as it can trigger a flare-up. So the back is done in a side lying or a seated position, and this is to prevent compression of the nerves on the and the face. They also recommend that you incorporate heat therapy. The heat can mobilize, soften, and relieve pain in the face. Massage therapy is also used to help these individuals relieve the stress and anxiety that they're afflicted with on a daily basis. With no known cure, it only makes sense to try and use neuroplasticity and therapeutic massage to try and treat this condition. There's this American philosopher. His name is William Jones, and he said that the greatest revolution of our generation is the discovery that human beings have the ability to change all aspects of their lives by changing the attitudes of their minds. And our neuroscience has proven that this is true. We're born with a blank slate with 100 billion neurons just floating around, waiting to get a connection. And most of these connections are a conditioned response or a learned behavior from birth and throughout our lives. But don't be fooled. Nothing in this life is hardwired. You can change those connections. So, in closing, my heart speaks. You should never change your mind to conform with what other people expect of you. You change your mind to create a new mindset. And if you do, you'll create a neural pathway that leads to a door that opens a brand new existence that's truly worth living. So this concludes my presentation. I'm sorry it was so wordy.
No.
It was informative.
It was very informative. It was not wordy. Some of this stuff requires wording. And I think Miss Savarino said it best when she said, I friggin' love Miss Avalos. So, I think that summed up a lot right there. I appreciate the holistic take on the thing and not just telling us about the condition. You guys probably won't see somebody with this condition actually flaring up in your place because it's so painful. You'll see them afterwards. If it comes up, there's nothing wrong with massaging them. Some people, by the way, describe this as so painful, like people, like horrible things, like clients asking to be shot. They're like, it's really painful for some reason when it flares up. Anyway, that was fantastic. I love that you mentioned the plasticity of the human mind. Couldn't agree with you more. And I think this is a great time to take a 15-minute break and come back at 9:55, everybody. Thank you. The suboccipitals today, and these are the muscles that exist in what I would say this little two-fingered area in the back of your head between your skull and C1 and C2. Some people call these the headache muscles. I think they're extremely important to work, extremely important. I do them on every massage. I mean, unless somebody comes in and says, just work on my feet or something. But in my general massage, I do them on every single massage. We're also going to talk, and we already talked about these, but we're going to review the splenius capitis and splenius cervicis, which are these muscles that kind of come from your spine and hook to your head, muscles that come from your spine and hook to your neck. They're all back here too. And we'll also review the semispinalis capitis, which is the speed bumps to your back, of your neck, sorry. And we're just doing that to see how your head is attached to your cervical region. Yeah? Oh, the chickens are okay. Oh, that's good too. So the chickens still have their splenius capitis attached, apparently. That's a good sign, yeah. All right. It's going to be a good day. All right, let me share my slideshow with you guys. Boom, boom. Here we go. By the way, on the person here right now, we can see the erector spinae muscles, and we can see what I'm guessing are the multifidi or the rotatories or something like that. It's not a very good picture, but it gives you kind of an idea. Okay. So we're going to be coming up here and talking about neck muscles that live underneath the trapezius, basically. The splenius capitis, splenius cervicis, semispinalis capitis, and the suboccipitals that are hidden under here. There's the suboccipitals. Super deep. So they're deep to the trapezius. They're deep to the semispinalis capitis. They're deep to all these other muscles. They are deep, deep, deep in your head. Yeah. You can see some of these muscles you can kind of see from the side. Okay. So, today we're going to be talking about the splenius cervicis, which comes from your spine to your cervical region. The splenius capitis, which comes from your spine to your cap. And then underneath all this stuff, they don't show it in this picture, but we're going to look at the suboccipitals, of which there's 4 on each side, 8 total. All right, let's take a look at those. So this is the back of the skull. Please look at the muscles that are cut here. I know I just said this already, but I'm going to say it again. In order for us to even be able to see these, they had to cut through the trapezius. They don't even show it here. Cut through the trapezius, they had to cut through the splenius capitis, they had to cut through the semispinalis capitis to get down to these muscles. And this is really blown up here because this is your occiput, the bone in the back of your skull. By the way, this right here is your external occipital protuberance, to give you an idea. If you feel on the back of your head, if you feel on the back of your head, this is that bump there. These muscles are just right, I gotta quit clicking on, these muscles are right below there. And just to give you a point of reference, I mean, this is the spinous process of C2. So this really is, the distance between here and here is about 2 fingers, width-wise. So it looks big in the picture. This is a very small area. These are very tiny muscles. We are not going to learn the action and the origin and insertion of your suboccipitals. We are going to learn the general origin and insertion because you're never going to be tracking down one occipital. You're going to be working in this whole region to loosen up the head. But essentially, these are your bobblehead muscles. They allow you to articulate and do little cute stuff around your head here. They help to lock your head onto your neck. And they are a place of extreme tension. So they're very important to work. I wanted to see more of them. Hold on. Right, there we go. We'll come back to this, guys. Let's look at the suboccipitals. So your book has done what it's always done. The 2 on the left here are not shown on the right, and the 2 on the right are not shown on the left, right? But you have a rectus capitis posterior major and a rectus capitis posterior minor. Longer and shorter. Both connect essentially to spinous processes. C1 doesn't really have a spinous process, but it's got a little spinous tubercle here. And so this rectus capitis posterior minor inserts into that. The major inserts into the spinous process of C2. So these muscles attach your skull to C1 and C2. The oblique capitis superior attaches your skull to C1, transverse process, and the oblique capitis inferior actually hooks C1 to C2. Again, please don't memorize this. I mean, you can if you want. You'll be a better anatomist than me because I don't memorize this. But I do want you to know that there are 8 muscles, 4 on each side, living back in this area that help you to articulate, to laterally flex, to rock and tilt, to rotate your head around. They're bobblehead muscles. But what we care about them is they also seem to cause headaches when they're really tight back here. And they're underneath a whole lot of other muscles. And so one of the best ways to get into these muscles is to put the head in an extension at C1, C2. Just like Mr. Overman just did. Thank you. The head goes back because when the head goes back, if the client's not helping me, if the client's helping me, it's a problem. But if the client is not helping me, that puts slack in the trapezius, it puts slack in the semispinalis capitis, it puts slack in the semispinalis capitis, splenius capitis, that's what I was looking for. It puts slack in all those so that they're not fighting me to get through them. You're not going to get through a tight trapezius to these muscles, right? So you don't want to bend them forward. If you guys bend forward right now, feel how hard the muscles are in the back of your neck. But if you bend back and let your head fall, so this is where you let somebody's head fall over your fingers. And you poke your fingers in. And then I actually, when I'm working the suboccipitals, I pretend like I am trying to separate their skull from C1. I pretend like I'm trying to dig in there between their skull and C1 and create space. And I am trying to create space in there. I'm trying to create an extra 1/10 of a millimeter in there to relieve the pressure. And that's what I do with this. But if you ask me for origins and insertions of the suboccipitals, I wouldn't be able to give them to you off the top of my head. I would just say, oh, these attach the head to C1 and C2, which is true. That's all I remember about them. But anyway, that's the suboccipitals, huge headache reliever stuff. I used to have a client with migraines. When she would get one, or thought she was going to get one either way, she'd have me come over to her house, and we kind of worked this area and other neck muscles and stuff like for an hour. That's what she liked done. So this is a really neat area. And if somebody can take it, you can dig in there. There's no danger. I mean, you can dig in there. If they can take it, you're not going to cause damage. You can really drive into the suboccipital region. Don't be afraid of it because it's the back of a neck. Just don't move it really quickly and don't see how far it'll bend back. But you can let it bend back and you can work in there as hard as you can. I've had clients push back against my fingers because they like it so hard. Just be careful, by the way, some people are hypersensitive back here because of all the tension and all that good stuff. So that's your suboccipitals. Your rectus capitis posterior, major and minor, right? The thing that goes to your head and runs roughly up and down, they're stretching it there, major and minor. The oblique capitis, the ones that kind of are off to the side here, inferior and superior, below and above. Makes perfect sense. And if you are to look at this and kind of think about all the muscles here together, the oblique capitis superior, just to think about it, attaches to the cap, to the skull here, and it goes to the transverse process of C1. Then the oblique capitis inferior, which is shown on the other side, would take off from the point that the superiors ended and go over here to the spinous process of C2. So oblique capitis superior and inferior tie the head to the transverse process of C1 and then tie the transverse process of C1 to the spinous process of C2. So they really do kind of follow this little trail here. I wish they'd kind of show them together so you could see that. And then the rectus capitis posterior, major and minor, both like to hook the skull to kind of the spinous processes of C1 and C2. The reason I'm saying kind of is C1 does not have a spinous process, but it's got tiny little tubercles on it that this muscle can grab onto. Tiny little bumps. Cool? Yay. Work those 8 muscles on everybody. All the time. Now let's go back. So, here are all of them together. You can see the, sorry, I just lost my slide here. I just had a little computer glitch. Bear with me. You can see, here we go. You can see the oblique capitis superior turning into the oblique capitis inferior, right? Attaching skull to transverse process back to spinous process on the next thing. You can see the rectus capitis posterior major and minor here, right in here. And you can see what a tight little web these 4 muscles all make together. All right. Splenius capitis and splenius capitis and splenius cervicis. These muscles are on top. They are superficial to the suboccipitals. This is why you have to rock the head back to get these guys to loosen up to let you in there. We talked about these last week. They really do go from your spine, your spinous processes, up to your skull. And one of the ones I'm very interested in is the splenius capitis because it attaches to the mastoid process of your temporal bone. And we're finding out that that is a high pressure area in your body because lots of stuff seems to attach to the mastoid process of your temporal bone. Yeah? You should be thinking of 2 other muscles right now. Hopefully the longissimus attaches to that same rough area, and so does your sternocleidomastoid. So, splenius capitis attaches to the spinous process, I think C7, which is this bump down here, up down to T4. And splenius cervicis is even further down. Splenius cervicis comes in and hooks into the transverse processes of your neck, C1, C2, C3. Can you guys think of another muscle you know about that inserts into transverse processes of C1, C2, C3, and by the way, C4, but it shares an attachment with this guy? Do we know another muscle that we've already learned? Mr. Overman, please.
Is it the levator scapula?
It is levator scapula. Thank you, sir. And remember, today we kind of learned about the scalenes. There's a lot of neck stuff going on up here that can cause people all sorts of problems. So this is another one. The splenius cervicis attaches kind of in that well, very much in those same spots, along with the levator scapula. And so that can cause all sorts of problems around the nerves in that area. Well done. Mr. Jones, please.
Oh, I was thinking it was the longissimus.
Well, the longissimus inserts into the mastoid process, but I was talking about the transverse processes of the cervical vertebrae.
Gotcha. Okay.
Yeah, you are right, by the way. The longissimus, the splenius capitis, and the sternocleidomastoid all have an attachment on the mastoid process of your temporal bone.
Okay, gotcha.
Yeah. The splenius cervicis hooks into the transverse processes of C1, C2, C3. The levator scapula hooks into the transverse processes of C1, C2, C3, C4. And the scalenes, between all the scalenes, you have 3 scalenes we haven't learned about yet, but posterior, middle, and anterior, they attach to all the transverse processes by the time you get through all the scalenes. So, cool stuff. So scalenes are going to become very important in problems with neck outlet syndromes, right? Scalenes will be very important, splenius cervicis becomes very important, and levator scapula becomes very important. I think, as crazy as it sounds, I think that's all your muscles for today. Yeah, we're not going to go through individual ones because I don't think it serves you. Here's this person articulating the head to get back in this spot, and you literally want to pretend like you're trying to get in between the vertebrae and the head. I even traction the head when I do this. Like I'm pulling back a little bit and rocking and really trying to get in there. I always make a joke with clients like, oh, your head's screwed on a little too tight. Ha ha ha. They're like, yeah. Anyway. So, it's a very tiny area. This picture makes it look a lot bigger than it is. It's not that big. Oh, this is a blank slide. Yeah. So ultimately, I put this in here. Ultimately, the suboccipitals tie the nuchal lines, which are the lines in the back of your skull that come out of the occipital protuberance here, to C1 and C2. They tie your skull to your first 2 vertebrae. Super important. Mr. Richards, please.
When I was looking it up, they said do like a chicken motion with your head, which stretches, like back and forth like a chicken rather than up and down.
Yeah.
That stretches and relaxes the muscles so you can get in there.
Yeah. Well, you're 100% right, sir. And when you, believe it or not, when you put the head in an extension, it's a little bit like protracting it, and that gets you that loosening there. You're absolutely right. And when it goes back and retracts, I think it tightens up. But yes, you're right. You can get this kind of pigeon kind of thing, or chicken thing. Yeah. So please play with this with people. This is a fun thing like learning to do feet, where you sit down and you just sit there and play with their head and articulate it and wiggle it around, and do not be afraid of it. If you are going slow, you can go hard and deep, and you can really dig in there. It's quite safe. Quite safe. Cool? All right. Questions about that so far? I'm going to have some questions for you guys. I'm doing this to highlight things that we've learned so far. So I'm not trying to quiz you. I am quizzing you, but I'm not quizzing you for the purpose of tripping you up. I'm okay if you don't know the answer. By the way, I'm not okay, though, if Miss Creo gives the correct answer, or I have to give her the correct answer, and then Mr. Craven, who I call next the exact same question, doesn't know the answer, because it means he wasn't paying attention. Does that make sense? So if you haven't gotten this question today, of course you can miss it. But if it's already happened, we've already mentioned the answer, then I would hope you would know. Miss Creo, I just picked on you because you were in my face on my screen, that's all. She's like, what did I do? Yes. Okay, so, hey, Miss Abelos, we're just reviewing. Miss Abelos, can you tell me the 4 rotator cuff muscles?
Supraspinatus, infraspinatus, teres minor, and the subscapularis.
Beautiful. Thank you. Mr. Overman, can you tell me the 4 rotator cuff muscles? And then we're going to add to it.
Okay. Got the supraspinatus, infraspinatus, teres minor,
Yes.
and subscapularis.
Beautiful, sir. Which one is responsible for an abduction of my glenohumeral joint?
That would be the supraspinatus.
Yeah, and everybody, he's right. And the reason he's right is in order for my arm to go out to the side, something had to lift it up. And in order to lift it up, it's got to be on top. And supra means up there. So that was perfect, sir. Sir, of these muscles, which one is responsible for a lateral rotation of my glenohumeral joint? Lateral rotation.
Lateral rotation, so coming out. Pull it in. So then infraspinatus and teres minor.
Yes, because in order for my arm to come out like this, you've got to be behind me pulling my arm back. And those muscles are behind me. The infraspinatus and teres minor are behind me. So, sir, which one would be responsible for a medial rotation?
The subscapularis.
Yes, because even though subscapularis is underneath the scapula, it's actually in front of me. Underneath the scapula is the anterior side scapula, and it really grabs here like this and rolls my arm in. Beautiful. Thank you, sir. Really well done. Super good. I love it. Yay! That's right. Miss Clayton. Miss Clayton?
Yes?
Miss Clayton,
Yes?
what are the muscles that attach to the medial border of the scapula?
Medial border of the scapula, that would be the rhomboid minor and the rhomboid major.
Yes.
There's the levator scapula. Well, that's the superior.
But still the medial border. Yep.
Okay. And then there's something on the.
There's one left that argues with the rhomboids.
The subscapularis. Yeah? No? That argues with the rhomboids?
Yeah. Subscapularis can't argue with the rhomboids because subscapularis doesn't move the scapula. Rhomboids do. And you are in the right region. I know why you said that. It's a common mistake and it's a good mistake because you're in the right area.
Is it below the rhomboids?
This muscle actually kisses the rhomboids. It actually attaches on the medial border where they do, but on the anterior side, whereas the rhomboids are found on the posterior side. It's very, very confusing. And
is it the serratus anterior?
it is the serratus anterior. Awesome.
Okay.
Ms. Clayton, so what were the 4 muscles that attach to the medial border of the scapula?
Levator scapula, rhomboid minor, rhomboid major, and serratus anterior.
Beautiful. Thank you, ma'am. Thank you. Awesome. I love it. Miss Carrillo.
Yes, head chef.
Miss Carrillo, first review with me what are the 4 muscles that attach to the medial border of the scapula?
Rhomboid major, rhomboid minor, the serratus anterior, and the levator scapula.
Beautiful. Which one or ones of those muscles can cause an elevation of the scapula?
Oh, shit. Levator scapula.
For sure, levator scapula. Absolutely.
Levator scapula.
That's the number 1 answer.
Yeah.
You could also, because the rhomboids do run diagonal, when they pull, they can lift a little bit. That's not number 1 answer, but just so you know, rhomboids major and minor can elevate the scapula. That's not what we normally think about them doing, but they can.
That's right, Christmas tree. Okay.
Yeah, Christmas tree. Which one or ones of those muscles can abduct or protract the scapula?
The protract is the serratus anterior.
Yes. Yes.
And then the abduct, I want to say.
Well, abduct is protracting.
Oh.
Yeah. Yeah, you answered both questions. They're both the same question. Abduct or protract. Yeah. Why don't you tell me, though, which one or ones can adduct or retract the scapula?
The rhomboids major and minor.
Okay. And you just described all the muscles that attach to the medial border of the scapula. You just described all of their movements. That was beautifully done. Is there a muscle that works with the serratus anterior? It's not attached to the medial border of the scapula, but it is attached to the scapula, and it likes to work with the serratus anterior because it too will also protract, abduct, and slightly depress the scapula, which is exactly what the serratus anterior does.
Slightly. I was going to say one of the pecs, but then you said depress, and that one kind of lost. It's the no way, it's not. It's the pectoralis minor.
Well, it's going down at an angle, so it can depress. It's in front, so it can protract and abduct. Good job, though. We're good.
The coracoid process. That's right.
Yeah, awesome.
That's right.
That was good. That was good. Thank you, ma'am. Those are hard questions. Those are really hard questions. Mr. Craven. Mr. Craven, can you tell me 3 muscles that have an attachment on the coracoid process? The coracoid process is this bump out here on your scapula. It's your scapula. It's a little beak-like production. But we now all know 3 muscles that have an attachment on there. It doesn't matter if it's the origin or the insertion, but there's 3 muscles that actually attach to this site here. Hold on. You're a little quiet. Let me turn you up. Hold on. What has got to be what, sir? Teres minor?
Or is that attached to the
No, just let Teres minor go. Teres minor runs from the lateral border of your scapula over to your humerus. But anyway, these muscles actually have an attachment on the coracoid process. One luckily has the name coracoid in it, basically. Yes, so everybody, he just described a muscle that literally looks about like my hand here. I mean, it doesn't look like my hand, it's about that length. And it goes from the coracoid process to the medial side of the middle part of my humerus. Yeah, coracobrachialis, that's number 1, sir, yes. And then can you think of another one? Biceps brachii. One of the heads of the biceps brachii actually comes over to the coracoid process. That is correct. Yep. And there's one more, sir.
You could just give me another hint. That would be
Another hint. Well, it's the same hint I gave Miss Carrillo. So, I don't know. What do I give you? Let me think about it for a second. So I'm just trying to come up with something that won't like give it away, but can kind of lead you in the right direction.
Well, I know that you're doing pec minor, right?
Yeah.
But I said that in the beginning.
Oh, I thought you said Teres minor.
Did I?
Yeah, you did, I think. Other people are nodding. Yeah.
That's what I meant to say.
Oh, because that's why I was like, you are way off on Teres minor.
I know it attaches on like the posterior side, so that's what I meant.
Yeah. Oh, good. Okay. Yeah, you were just using different words for different things. Sure.
Minor in it.
Yeah.
Minor was there.
Elephant's the right word. I was thinking about pec minor. Cool. Yeah. So we got pec minor attaches to this thing, biceps brachii attaches to this thing, one of the heads does, and your coracobrachialis. Thank you very much, sir. That was great. Yeah. Miss Deng. Hi, Miss Deng.
Hi.
Can you, I know this is hard, so it's okay. I just asked Mr. Craven this question. I'm going to ask you the same question. What 3 muscles attach to my coracoid process?
I heard, but I didn't know how to say. Can Can you teach me then for you say again?
Yes, I love that. Can I teach you? And yes, you'll say it again. Yes. Pectoralis minor.
Pectoralis
Minor.
minor.
Yes. Let's say that one again. Pectoralis.
Pectoralis minor.
It's kind of like your daughter's name, Pectoralis.
Pectoralis
Yes, pectoralis minor.
minor.
Yay. Pectoralis minor. The next one is coracobrachialis.
Brachialis.
Nice. Coracobrachialis.
Brachialis.
Nice. And the last one is biceps brachii.
Bicep brachia.
Yes. All right. So, pectoralis minor. It's hard. It's hard. It's okay, Miss Deng. Pectoralis minor.
Minor.
Coracobrachialis. I went too fast. No, it's my fault. Coracobrachialis.
Brachialis.
Beautiful. And last one, biceps brachii.
Brachia. Thank you, sir.
Thank you. Very brave. It's not easy to do in front of a group. Thank you. Mr. Lee, let's repeat this. Mr. Lee, sir?
Yes, sir.
Mr. Lee, what are the 3 muscles that attach to the coracoid process? I just did it with Miss Deng.
Yes. Then try how to proceed. Protect.
I could do it with you too, sir. I'm happy to do it with you. That's
Yeah,
why I
sure,
called it.
please.
Okay. So, pectoralis
Pectoralis
minor.
minor.
Coracobrachialis.
Brachialis.
Biceps
Biceps
brachii.
Yes, sir.
So what are those 3? Say them for me one more time. Pectoralis minor.
Pectoralis minor.
Coracobrachialis.
Coracobrachialis.
Beautiful. Biceps brachii.
Biceps brachii.
Nice job, sir. Thank you.
Thank you.
I love that.
Thank you.
Thank you. It's good stuff. And by the way, everybody, what I'm doing is actually really in some ways emphasizing muscles that attach all to one spot, right? If that makes sense. Mr. Ma, what are the 3 muscles that attach to the coracoid process?
Pectoralis minor,
Yes.
brachialis,
Yes.
Biceps brachii.
Yes. That was perfect. That was absolutely perfect, sir. By the way, everybody, don't be afraid to do these signals, right? Pectoralis minor, coracobrachialis. It gives me a rough idea of the length and location and everything. It's very helpful stuff. That was well done. Thank you, sir. Thank you.
Thank you.
Let's see. Miss Dimitruk.
Yeah.
Miss Dimitruk. Sorry. Hey, it's a happy day. You got all the chickens. Yeah.
Got the chickens.
Chickens. Miss Dimitruk, we know 3 muscles that like to attach to my mastoid process of my temporal bone. This bump back here behind my ear. Can you tell me what those 3 muscles are?
The longissimus, the spleni capitis, and one of them little tiny ones we just learned about today.
No. I'm going to say a prayer for you and help, and I hope it'll help.
Oh, sternomastoid occlutus in Britain.
Sternocleidomastoid, but that was even better. Sternocleidomastoid. So what are those 3 muscles again?
Longissimus, sternocleidomastoid, and splenius capitis.
Yes, thank you. Splenius capitis, everybody, is a muscle that goes off kind of diagonal, comes through your spine and goes out to the sides. That's how it gets up here. Yeah. And then the prayer muscles right here, sternocleidomastoid, and the longissimus, remember, attaches my head all the way down to my butt. Really well done. Thank you, Miss Dimitruk. Hey, I want everybody to know, I've said this before, but I need to say it again. There is nothing harder in the world than having somebody call on you in a group, a random question that you don't know what it's going to be, and you have to extract that from all these Latin words and try to regurgitate that, right? If Mr. Ibarra was here asking me questions right now, it would take me quite a while to be like, to access that memory, to know where he's going with it. So I would have a really hard time with this too. I expect you to be like, Coracle, what? What are you talking? I don't know. You know, I expect it to be hard. So please don't ever feel like you need to be perfect, any of you. You just need to be present. That's it. Miss DeBose.
Yes.
Miss DeBose, what are the three muscles that have attachments on the mastoid process of the temporal bone?
The sternomyoclastoid.
Mr. Mitra just started a craze. No, you are very good. Sternum, clavicle, and mastoid. Sternocleidomastoid mastoid.
Okay. Sternocleidomastoid.
Yes.
Okay. The splenius capitis.
Yes.
And the longissimus.
Yes.
Okay.
Yes. Beautifully. That was beautifully done. Thank you, ma'am. Thank you. Thank you. I love it. All right. Okay. Everybody, I will call on some more people tomorrow, but I think I should give you time to work on your homework. Not because it's awful, but just because that way you're not completely inundated, because we have time. So give me just a second here to pop up your homework. You have 2 homework assignments. A 23-question quiz on the suboccipitals and splenius capitis, stuff like that. And matching on chapter 24 on the endocrine system. Because we will be talking about your endocrine system tomorrow, which is essentially your hormonal system in your body. All right. Everybody should be able to see that stuff right now. You have time to work on that right now. Please don't feel left out. If I didn't call on you, you might feel relieved. I don't know. But I will not forget about you. Trust me. I will be coming for you.